All right, we are at 2 o'clock, so I'll get started here as folks are trickling on. So hello and welcome everyone to another MMS info session. As you know, these sessions are offered under the CMS Measures Management System contract, which is held by Battelle. I am Brenna Rabel, and I oversee education and outreach on this project. Today's session is all about patient-reported outcomes and measures associated with them. So I'm going to be presenting on patient-reported outcomes-based performance measures, providing some important definitions, and then turning the presentation over to our co-presenters from the National Quality Forum, Chuck Amos and Teresa Brown. So as you know by now, these sessions are part of an ongoing effort to engage measure developers and other stakeholders in quality measurement topics. And that's an effort that also includes a series of newsletters and bulletins, along with special announcement emails, public webinars, and routine updates to the Measures Management System website. We are happy to report that this year we are resuming doing these info sessions on a monthly basis and have been since January, so that we can continue to provide up-to-date information on a wide range of topics related to quality measure development. Before we jump into the presentation, I just want to cover a couple of housekeeping items. The first is that today's session is being recorded. Second, all participants are muted during the call. We are going to have an opportunity for Q&A at the end, during which we encourage you to enter your questions into the chat feature, and then we'll queue them up from there. And then finally, the presentation slides from today's session have already been posted to the MMS website for your reference. They'll be updated in a week or so with notes from today's session. And then the recording of today's presentation will be posted to the CMS YouTube page at a later date. So once again, I'm going to be presenting on considerations for developing and testing PRO-PMs. So I'll talk a bit about some of the challenges associated with specifying and testing these types of measures. And I think that'll transition nicely to NQF's presentation, which is going to cover key findings from a technical expert panel-based project related to selecting patient-reported outcomes for use in clinical settings. And then, as I said, we'll open up the floor for discussion. Our goal today is really just to convey not only what PROs, PROMs or PROMs and PRO-PMs are, but also to explain their importance in the context of CMS quality measurement, and to explain why their use is such a priority, despite some of the unique challenges that are associated with them. And while many of you do not necessarily work in clinical settings where PROMs may be implemented, we do hope to highlight how NQF's work on that front can impact future measure development efforts. So before we get into the meat of this presentation, let's just start with a pretty foundational question. Why does CMS prioritize the use of patient-reported outcomes-based performance measures? And first and foremost, it's that these measures, which rely completely on patient perspectives about the quality of their own care, are very directly deliver on the promise of patient voice in value-based payment. And further, they're outcome measures, which ensures that we're evaluating the actual results of care rather than the clinical processes that we hope will result in better outcomes for those patients. And when we allow patients to report on their own experiences using tools that track outcomes that patients find to be meaningful and important, we have the basis for inherently patient-centered measures. And that is the appeal of PRO-PMs. So that said, there are important ways in which clinicians and measure developers can promote patient-centeredness, namely by ensuring that the data collection tools that are used to collect these outcomes have been selected with patient preferences in mind. Our NQF colleagues will talk about this in some detail during their leg of the presentation. But in general, PRO-PMs offer a unique pathway to better outcomes and improved delivery of patient-centered care. So now we'll get into, as I said, some of the considerations that go into developing and testing these types of measures. So first, I just wanted to kind of define these key terms. It can be a little bit confusing to see all of these acronyms next to one another, so I wanted to make sure that we're all on the same page. When we talk about a PRO or just patient-reported outcomes, we're talking about what's getting measured. So literally, what is the outcome that the patient is reporting? So it's the status of a person's health condition or health behavior or experience with healthcare, and it has to come directly from that person. The PROM, or the patient-reported outcome measure, is actually how the patient-reported outcome is measured. So it's the tool or the instrument that's used to collect that data. You know, I think some people will use PROM interchangeably with PRO-PM, largely because of that M, right, for measure. But for clarity, it's really important to note that the PROM is the data collection tool or instrument that's used to collect patient information, and the PRO-PM is the performance measure that you would see used in something like a CMS program. And on the next slide, I'm going to show you a couple examples of these. Right, so, you know, for a PRO, you might think of something like functional status after knee replacement surgery, right? So after somebody has had their knee replaced, there are probably a couple things that those patients are interested in being able to track and talk to their doctor about, right? How has their quality of life changed since the surgery? How are their symptoms? What's been their overall experience with the different doctors that they've seen for that process? And then any other kind of global, you know, health like behaviors that they might want to, that might be tied to having had that surgery. So the PROM in this case would be any tool that collects patient-reported data related to that knee replacement surgery. And that might be a global tool, something like the PROMIS, which asks questions not just about the, you know, pain and function of that joint, but also asks questions about you know, general health and wellness, including mental health, or it might be something that's more specific to that particular procedure, like the WHO's or the KOOS or the KOOS Junior. And then the PRO-PM is the measure that's based on it, right? So the functional status assessment for total knee replacement is an example of a PRO-PM, and I'm going to show you what that looks like here. So just to drive home that point, distinguishing PRO-PMs from PROMs, here is an example of a PRO-PM. So looking at functional status assessment for total knee replacement, it's the percentage of patients 18 years of age or older who received an elective primary total knee arthroplasty and completed a functional status assessment within 90 days prior to the surgery and in the 270 to 365 days after the surgery. So you can take a look at this numerator statement on the left, and you can see that this measure allows for the use of more than one type of PROM or tool, including the VR12, the PROMIS-10, and the KOOS Junior. This measure is looking very simply at the percentage of patients that had a primary knee arthroplasty or knee replacement, whose doctor conducted a functional status assessment both before and after their surgery. Now, you might be thinking, that's not an outcome, and you would be right. However, as I'll discuss momentarily, a major challenge in developing PRO-PMs that look at pre and post scores is the availability of sufficient data. In a lot of cases, clinicians don't have consistent post-intervention data from patients or haven't been using the PROMs long enough to accumulate enough data to calculate a reliable performance score. So as a result of that, process measures like this one can be used to promote the use of validated PROMs to serve as the foundation for future outcomes measures that look for changes in PROM scores before and after interventions. So now I just want to touch on a few unique considerations that measure developers keep in mind when evaluating PRO-PMs. You know, they have to be evaluated against the same criteria as any other measure, but they have a few kind of specific considerations associated with them. So I'm just going to walk through those briefly. You know, for the importance criterion, developers have to demonstrate that both the performance measure and the PROM it's based on are patient-centered and that patients were involved in identifying the outcomes being measured. And there are a few different feasibility considerations that go beyond kind of the normal requirements as well. Namely, that PROMs can be burdensome for patients to complete, especially if they have to be completed in person at a clinician's office. So things that a developer might consider are whether the method of collecting the information might systematically discourage specific groups of would-be respondents from completing them. So are the sickest patients going to be the ones answering these, getting long-term values in these fields? And then there's also important potential like language, literacy, and cultural issues that could impact the completeness or validity of the resulting information as well. So thinking about things like the level of difficulty of the language in the tool, or whether the tool is offered in more than one language, for example, are all things that impact the feasibility. For scientific acceptability, it's most important to know that reliability and validity must be established not only for the data measurement instrument, so the PROM itself, but also for the performance measure. It's important that PRO-PM specifications include details about the methods of administration. So in other words, whether the tool is administered in person or via a patient portal, a description of how proxy responses might be handled, and details about how response rates are calculated and how the responses might affect results. For usability, it's crucial that providers are able to use the information from the tools to improve the quality of care they deliver. So it's important that these measures, in other words, have equal utility in both quality improvement and quality measurement. And finally, the PROM itself must be psychometrically sound. And this feeds into the scientific acceptability criterion, but it's still worth noting on its own because it really is crucial that the PROM on which a measure is based has sort of been validated on its own. And finally, it's worth noting that PRO-PMs have to be patient-centered, meaningful, implementable, and amenable to change. They should reflect collaboration and shared decision-making with patients. Patients become more engaged when they can give feedback on outcomes that are important to them. These measures should capture impact on health-related quality of life, symptom burden, experience with care, achievement of personal goals as relevant for the aspect of care that's actually being evaluated. Now, not every measure needs to address all of those things, but it's important that PRO-PMs are varied in that sense, and that we're thinking about all the different ways that a patient might think about the success or failure of a given intervention. The outcomes of interest have to be responsive to specific healthcare services or interventions. So in other words, clinicians need to be able to use the information from these measures to make changes to their own practices or decisions to improve patient outcomes. They can't be static. And then finally, developers have to consider the potential challenges associated with the implementation of such a measure. So going back to what I was talking about under feasibility, data collection directly from patients involves challenges, including additional burden to patients, health literacy issues in terms of the patient mix that a given clinician might see, the cultural competence of providers, and then even things like adaptation to computer-based platforms like patient portals. So during development, developers really need to plan to evaluate the extent to which these challenges apply to their measure and consider ways to manage them. And as I mentioned earlier, common challenges that measure developers might encounter largely relate to data availability, both in terms of the availability of PRO data in an extractable format and insufficient pre and post data. NQF's presentation is going to touch on work that's pretty foundational to improving data collection in clinical settings. But further, some PRO-PMs, like the one I shared with you earlier, allow clinicians to use different PROMs to collect data. In a process measure, that's not a major challenge, but measure developers seeking to measure outcomes may struggle to account for differences in PROM score from patient to patient or from clinician to clinician when more than one tool is included in the measure specification. So these are challenges that need to be evaluated throughout the measure lifecycle, but especially during testing and specification. The blueprint does include some supplemental material on the topic of PRO-PMs, so I've included that link here. And again, this presentation is already up on the MMS website resources page, so you can reference that. So feel free to visit that site or to email us at mmssupport@battelle.org if you'd like a little bit more information. And with that, I'm going to turn the presentation over to Chuck Amos at NQF to talk us through some best practices on selection and data collection of PROMs.
Wonderful. Thank you so much, Brenna. It's an honor to be here with you today and with everybody on the call and to share these recommendations on best practices for selecting and implementing PROs and PROMs. I also want to thank CMS for funding this work, and particularly our panel of experts who are the thought leaders behind this report. Without them, we wouldn't be be here today sharing this information. So again, I'm Chuck Amos. I'm a Director of Quality Innovation at NQF. Prior to joining NQF, I led the collection and use of PROM data for a health system-based ortho practice. I also spent many years leading quality improvement work for underserved populations and FQHCs. And before I shifted into quality, I spent about a decade developing EHR systems. I'm also here with my colleague, as you said, Teresa Brown. Teresa is a senior manager of quality measurement at NQF. She's worked in hospitals, home healthcare, and healthcare quality for close to 15 years. She started out clinically as a patient care technician and moved into quality improvement and management positions starting about 10 years ago. Next slide. So I'd like to start just by sharing a little bit about NQF. I'm guessing most of the folks here today know us for our measure endorsement. NQF endorsed measures are used in federal public reporting and pay for performance programs, as well as in private sector and state programs. So endorsement is certainly a significant part of our work, but it's not all that we do. We partner with diverse stakeholders who work together to drive measurable health improvements for the benefit of patients and for the entire country. These partnerships enable us to serve as a neutral convener for important work outside of endorsement, such as consensus-based measurement frameworks and health equity initiatives. I've only been with NQF for a few years, but one of my favorite things about the organization is seeing how organizations who don't typically collaborate are willing to come together at our table and work to improve healthcare for all Americans. So I hope as we talk through the details of these recommendations for PROs and PROMs, I hope that you're going to see that collaborative spirit of work. Next slide. So Brenna, you gave a wonderful overview of the background to this work. I'm going to go through these next few slides fairly quickly. If we look at the next slide, I'll reiterate Brenna's comments about terminology very briefly. The terminology in this work, it can be very confusing, and it's not unusual, as Brenna mentioned, for even experts in the field to occasionally use the terminology interchangeably. For the purposes of our discussion today, again, PROs are what we're measuring, such as improvement in symptoms of depression. Like Brenna said, PROMs are the how, the standardized questionnaires that we use to collect data from patients on the outcomes. So again, running with the depression example, a common PROM would be the PHQ-9. We won't talk on the NQF side, we won't talk much about PRO-PMs today, but those are the performance measures that we use to assess and compare healthcare entities. So to complete the depression example, NQF has a measure number 0711, which is shown in the lower right there. Our next slide. CMS and NQF do have a long history of collaborating to advance PROs. Our work in 2012 and 2013 set the stage by defining PROs, PROMs, and PRO-PMs, explaining how NQF's evaluation criteria apply to PRO-PMs, and then identifying the important attributes of an impactful PRO-PM. The work was expanded upon by David Sella and his colleagues in a 2015 report, and then in the subsequent years, we've heard requests for more technical guidance for the PRO-PM development process. CMS wisely believed, though, that it's really important to start by examining PROs and PROMs, since a PRO-PM's not going to be impactful if the PRO of interest isn't meaningful to either clinicians or to patients. So similarly, a PRO-PM, the performance measure, isn't going to move the needle in health outcomes if the data are collected by a poorly designed or implemented PROM. So that's why with this project, NQF focused on PROs and PROMs before moving on to PRO-PMs. For this PRO best practices project, we saw expert input on how to select a PRO, how to select a high quality PROM, and then how to implement that PROM successfully, meaning that it collects good data. Next slide. So before we get into the content of the final report, I want to talk a bit about how the recommendations in the report came together. The next slide. The purpose of this project was really to help clinicians as well as researchers, administrators, other people who are working in a clinical setting and health systems, identify and overcome the challenges that go along with selecting PROs and then selecting and implementing the PROMs. The work was guided by a technical expert panel, or a TEP, that came together for about a year to develop the recommendations. This panel was chaired by Christine Norton from Minnesota Community Measurement and Albert Wu from Johns Hopkins. And it was composed of about 25 diverse patients, clinicians, researchers, measure developers, health IT experts, a range of experts from across the healthcare and patient-reported outcomes spectrum. In addition to the final report, the group also guided the creation of an environmental scan. Both of those reports are available on the link that's near the end of the slides. The next slide. So the historic work identified 5 categories of PROs, and the TEP unquestionably agreed that all 5 are important, but the TEP recommended that the final report focus on PROs that relate directly to health outcomes rather than either patient behaviors or experience. As such, the recommendations in the final report primarily address health-related quality of life, which are things like energy and mood, functional status, are activities of daily living like bathing and dressing, and then symptoms and symptom burden, such as pain and fatigue. Next slide. One topic that was really important during the TEP's discussions was the continuum on which disease-specific and disease-agnostic PROMs sit. On one side of that continuum are PROMs that are relevant across multiple health domains for people who have or do not have chronic conditions. And then on the other side of the continuum are PROMs that capture patients' perceptions, symptoms, and impacts as they relate to a specific disease or condition. It's common to try to view disease agnostic and disease specific PROMs as binary, but the TEP strongly encouraged framing these on a continuum, knowing that even PROMs that are specific to certain diseases can have relevance across different settings. And an example we talked about with the PROM was, again, using depression, the PHQ-9, which sits closer to the middle of the continuum due to its use also as a screening and assessment tool in primary care settings. That's compared to an instrument like the KCCQ-12, which is specific to patients with congestive heart failure. So just a takeaway from the TEP there to really view the spectrum on a continuum from disease specific to disease agnostic. And our next slide. So with that context in mind, let's go ahead and jump into the recommendations that came from the expert panel starting here. So starting with the selection of patient-reported outcomes. Again, patient-reported outcomes are the health outcomes we want to track. So this is where a care provider asks the question, what outcomes are important to our clinicians, our leaders, our payers and regulators, and to our patients and their caregivers and families? The TEP identified 4 key recommendations. So the first is to actively engage patients, caregivers, and family members in the selection process. Patients can come from places like a patient and family advisory council, but the TEP also highlighted the value of looking at some of those patients who can be, I'm going to put this word in quotes here, but who can be scary to interact with. You know, the patients who are calling to complain or maybe have had a bad outcome. Because if you manage that relationship and really engage those patients, oftentimes those are the patients who are going to become your strongest partners in elevating the patient voice. A couple of themes that you're going to hear throughout the presentation today are the importance of selecting patients who represent your population, and then ensuring you have a diversity of patient voices. one patient cannot speak for all patients who are seen by a clinic or a health system. Now, of course, patients are only one voice at the table. The TEP really wanted to emphasize that it's important to engage clinical expertise as well. Again, a diversity of opinions is important here, and as with the patients, it's valuable to engage dissenters as well as the champions of PROs, as long as the dissenters are open to discussion and willing to change their opinions and consider new information. Additionally, it's important to look at the clinical and strategic goals that are in place and to align your patient-reported outcomes with these goals. And then finally, it's absolutely critical to build consensus, not only around actionable PROs, but also around the workflows that are going to be used to capture the data. Teresa is going to talk a lot more about the workflows in a few minutes. Next slide. So once the group has decided which PROs to prioritize, they then need to select questionnaires or PROMs for the data collection. The TEP identified 5 recommendations for PROM selection. I'm not going to read through everything here, but I do want to touch on a few key points. Again, the TEP said it's absolutely important to include patients, families, and caregivers in these decisions. Patients offer unique perspectives that the healthcare workers might not fully understand or appreciate. Things like language barriers on certain PROMs that are going to disproportionately affect your population, or digital barriers that a population may not have access to the portal or the tools to complete the PROMs. When I worked at the orthopedic practice, we learned an interesting piece of information about one of the disease agnostic PROMs we used by talking to our sports medicine surgical patients. A lot of these surgical patients were high school and college athletes, and there were words on the questionnaire we used that weren't part of the Generation Z lexicon. So these young people didn't understand what we were asking. It's important to engage a diverse group of patients who span different races, ages, and genders while still reflecting the people you serve, so you can tease out and make sure your PROMs are accurately capturing data from your population. The second, third, and fourth bullets here all speak to the different PROMs that are available. There are a lot of PROMs out there, and the importance of finding which are best for your needs. The report advises the selection team to do things like talk to their peers in other organizations, talk to specialty societies, and just learn about which instruments are available, which ones are widely used. Different PROMs can focus on different quality of life, functional status, and symptoms. So it's also important to work to identify a tool that measures what's important to you and your patients. And then it's also important to recognize that you may identify an outcome that can't be captured by a single existing PROM. So you might need to either look at combinations of PROMs or revisit your selection of PROs. The last point on this slide, it's one we all know, it's one everyone I've met hates to do, but document your work. The TEP really stressed this. If you're leading the selection process, it's possible that you might want to accept a promotion or maybe retire someday. So document the work you've done so future selection committees and leaders can build on that work. Next slide. For me, one of the most exciting things that came out of this panel's work was our attribute grid. It's included as Appendix D in the report, and this grid looks at the attributes of PROMs that your selection committee should be considering. It presents the attributes in a way that you can compare multiple PROMs against each other. Brenna at the beginning talked about a lot of important qualities, things like psychometric soundness, obviously an important attribute to consider. But the grid also looks at things like the cost to license the PROM. That's an issue that can be really important for large health systems that are weighing a free instrument like the Hoos Jr. for hip replacements against an instrument like the Oxford Hip Score that has licensing costs. CMS asked the TEP to deliver a practical working tool, and the TEP's work in developing this attribute grid was really a wonderful accomplishment and a highlight of that work. So with that, we can move to the next slide, and I'm happy to introduce my colleague, Teresa Brown. Teresa, it's all yours to talk about implementation.
Sure, thank you, Chuck. Next, we will go through and build off of some of the topics already covered, talk through 5 key best practice areas and promising practice areas on data collection, as well as some additional considerations. Next slide, please. Intentionally presented and discussed first, achieving stakeholder buy-in was one of the TEP's key recommendations and a critical best practice for successful implementation. While also mentioned in the previous section, our first bullet includes clinical champions with emphasis on providers. Additionally, there's a need to look for buy-in from key stakeholders throughout the process, including high-level management, administration within the practices, and those in the practices administering the PROMs. From the panel, the importance of learning from peers and peer organizations, following concrete successes in PROM collections, and understanding workflows, bring those back and help practices not have to reinvent the wheel each time. For those looking to implement clinically specific PROMs, ensure that you talk to societies and connect with others to help improve and increase the cross-stakeholder buy-in. Next slide, please. Related to the previous slide, burden will likely be raised as part of the conversations early within the implementation process. Patient and clinician burden need to be addressed, with clinician burden associated with the learning curve of implementing new processes, and patient burden specific to the quality and quantity of paperwork, forms, and information that they are asked to provide prior to a clinical visit. Clinician burden can be addressed and reduced through PROM-specific education, well as workflows, and efficient uses of technology to improve usability as part of the clinical visit, all of which we'll be covering in the coming slides. This perceived burden should reduce once results are integrated and can prompt action and treatments as part of each visit. Patient burden can be addressed by specifically reducing the amount or content of the questions and paperwork when not absolutely applicable or necessary, as well as emphasizing outreach to those patients who may not be able to access electronic forms independently due to any number of circumstances. Additional modes and modalities need to be explored for these groups to guarantee vital information while not introducing undue burden to these patients. Next slide, please. For workflow, there are several different ways to approach this process. The TEP strongly suggested an organization begin with a PRO and PROM implementation with the use of a pilot program in one or a small subset of practice or outpatient clinics. Building from the peer-to-peer buy-in and external resources, starting with one clinic to refine and develop a working process and workflow can help institute cross-stakeholder buy-in, as well as ensure success throughout the organization. Using tools such as process mapping and involving all key stakeholders early in the design process will help ensure that both design and implementation go successfully. Introducing a quality-focused Plan, Do, Check, Act cycle, PCA, to reassess this process and make sure any adjustments are made once fully implemented. Ideally, using data electronically as part of the clinical visit will help ingrain PROM completion and results into the workflow. Those clinical and administrative leaders, as well as those in the offices collecting information, should serve as organizational champions and invest dedicated time and resources for those pilot staff to help mentor practices during their rollout. Next slide, please. Being able to understand PROM results and discuss the scoring and cut points is imperative to clinician use and successful implementation. Examples provided in this slide, such as blood pressure readings or an LDL result, should help illustrate how easily and readily available the information and education PROM results should be to a clinician. Actionability goes hand in hand with interpretability, and clinician use is dependent on being able to gather this information and help determine best treatments for the patient. Next slide, please. Realizing that in addition to the previous challenges discussed, technological challenges with EHRs is an area of ample opportunity. While other topics discussed in this section reflect best practices presented by the TEP, integration with EHRs is specifically noted as a promising practice, as this area is yet to be streamlined. Currently, some EHR vendors do have PROMs built into their systems, and many organizations are building their own or using third-party applications to administer PROMs to patients. All of these are realistic options, depending on the organizational needs and resources. For those PROMs that include electronic PROM administration and use, storing data in a meaningful way, such as tracking and trending progress over time, dashboards allow early notification how results can be interpreted and acted upon, similar to a critical lab result being highlighted in a dashboard for a clinician. Ideally, interoperability challenges within this area should be minimized over time, but there are encouraging examples and success stories here to help improve PROM implementation. Next slide, please. There are additional considerations in implementing PROMs within an organization. An organization must realistically assess their resource availability, including time, expertise, IT infrastructure, and dedicated personnel before developing a plan to implement PROMs. As previously discussed, patient population must be considered in the early planning stages of PROM implementation. Return on investment is a largely unpublished area in PROM implementation. We heard arguments from the TEPs that wide PROM and PRO collection can lead to, or could lead to, better clinical outcomes, improved satisfaction, and even reduced mortality or rehospitalization rates. These are largely anecdotal for now, given this preliminary work. Incentives are also discussed at length, and due to the nature of this information, the efficacy of both patients and clinicians for incentives is largely unknown. This includes a wide range of ideas, such as offering patients free parking when they fill out their PROM prior to an appointment, or reimbursing clinicians just the same as if they were to order a diagnostic test. Organizational oversight and governance of implementation activities include the oversight and training of implementation activities within an organization, and ethical and legal considerations are consistently brought up in the framework. If a patient identifies a certain outcome, what is the clinician's responsibility or liability for acting on that outcome? Next, I will hand it back over to Chuck to discuss a use case example provided in the PRO report.
Thanks, Teresa. I was talking with a former colleague a few months ago, and she's helped a number of practices select patient-reported outcomes and then identify and implement the PROMs they're going to use. She wasn't involved in this technical expert panel. She wasn't involved in this report at all. She didn't see it until it was done. And when she read the implementation recommendations that Teresa just discussed, she told me that she wished she had had this guidance when she started working with PROs about 10 years ago. As somebody who's lived these challenges, she was thrilled to see the TEP's recommendations coming out, particularly with regards to those implementation steps that Teresa just identified. So the recommendations report also considers 3 use cases, looking at how different stakeholders involved with joint replacement, heart failure, or burns and trauma might interact with PROs and PROMs. Our next slide. I'm not going to go into great detail about the use cases. It's a fairly detailed part of the report, so I'm going to look at joint replacement at a high level and then encourage any of you who are interested to download the report and take a look at this section. The use cases begin by looking at some potential outcomes for joint replacement. This includes things like improved functioning or reductions in pain compared to the preoperative baseline. Next slide. The use cases then look at recommendations through the lens of different stakeholders, including patients and providers. So this is a snapshot, very high level, of the patient use case for joint replacement. You can see the themes on the left in the blue, things like patient-reported outcomes, and then if we look over on the right in the gray, you can see how is the outcome meaningful to the patient, really a theme that emerged throughout this work. Or is the questionnaire burdensome to complete? Does the patient understand the purpose of the PROM and the score it generates? The next slide. And if we look at the joint replacement use case from the provider perspective, we've got the same, almost the same themes over on the left in those blue boxes. So you see those themes overlap with the patient perspective, though we've added the addition of PROs in a clinical setting. So how these themes are interpreted, so these themes look at the different interpretation between providers and patients. So whereas the patient perspective on PROs looked at things like the meaningfulness of the outcome, the provider perspective is going to look at things like whether the outcome is actionable, how it reflects the recovery process. Again, I don't want to go deeply into this, but for anybody who's interested in these use cases, I absolutely encourage you to download the report. Our next slide. So we're going to, I'll share the link momentarily. It's in the slides. Just a heads up though, if you Google NQF PRO best practices, that report should be one of the top results, a little easier to get to it that way. And our next slide. So this report was published in September, and in the months since then, 3 things about the project have really stuck with me and stood out to me. First, the TEP, as you've heard here, the TEP clearly stressed that patient, family, and caregiver involvement in the decision-making processes, it's essential, and it's got to coexist along with the clinical perspectives. I think the second thing that stood out to me is the importance of getting buy-in from those key champions. Like Teresa said, not just the clinicians, but the key people in the operations staff, the ones who are going to be executing and enforcing the workflows, as well as executive leadership, who's going to ensure that resources exist for collecting, analyzing, and acting upon these data. Then the third thing that really stands out to me is the use of the attribute grid and how that use can eliminate reinventing the wheel that currently occurs when practices want to start collecting and using information on patient-reported outcomes. You know, mirroring the sentiments of my colleague, even when I started working with PROMs a few years ago, I wish this report had existed and this knowledge from the TEP was collected in one place. So I'm really grateful to CMS and to the TEP for ensuring it exists now. As we look ahead to future goals, there's an enormous amount of exciting work ahead of us. We need to integrate PROM data into the clinical workflow, make sure those PROM scores are discussed the same way, like Teresa said, the same way that blood pressure or LDL is discussed. There are vast opportunities to improve how PROM data are captured and stored in EHRs. There's a lot of interesting work to be done around both patient and clinician incentives for using PROMs. And then, of course, there's the intersection between high-quality PROMs and PRO-PMs. And that takes us into the task order that we're currently working on with CMS. And why don't we go to the next slide, and Teresa, I'll hand it back to you to talk about the current project.
Sure, thanks, Chuck. As mentioned previously, we are in the base year of the next project within this topic area, exploring PROs, PROMs, and the transition to PRO-PMs, and are focused on bringing this conversation forward. Next slide, please. The purpose of this current task order is to identify attributes of those PROMs that have been used by CMS and develop a step-by-step guidance for using these PROMs to develop high-quality PRO-PMs. This guidance will be the last deliverable in the base year of this task order. We are looking forward to that. Currently, we are working on wrapping up the environmental scan, starting to draft an interim report, focusing on those attributes that a PROM must have to be deemed high quality, and then determine which PROMs should be focused to develop future PRO-PMs. Next question, or next slide. All of the project's web meetings are open to the public. So this slide does include upcoming dates and the high-level topics that will be covered. This does include a web meeting for tomorrow. And the project page is going to be listed in that contact slide for any additional detail. We do invite anyone interested to attend these web meetings and allow public space for public comment towards the end of each meeting. Next slide, please. As touched on previously, the environmental scan is in the later phases and will be posted publicly on May 18th. And the final 2 reports will be open for public both in June and in September. And we look forward to any additional information in any public comments. With that being said, I believe we are moving on to Q&A in the next slide.
Yep, thank you so much, Chuck and Teresa. We can actually jump 1, 2, 3 slides. So on the next slide, you'll just see contact information. So that's there on the website. I just wanted to note to folks, you can still feel free to enter your questions into the chat feature and we will read them aloud here. But just to kind of get the discussion started, I wanted to, I guess, turn it back to our NQF colleagues and ask if you could sort of summarize, down to like 2 or 3 primary takeaways from the work that you did around PROM selection, in terms of what it means for, the next phase of patient-driven outcomes measures. If you could speak to that a little bit.
Sure, I'll take a first stab at that, and Teresa, please jump in. I think, and just to make sure I heard the question correctly, 2 or 3 key takeaways specifically for the PROM selection, right?
Yes.
Perfect. Again, I think for the PROM selection, and it's the overlap with the PRO selection, is just the importance of engaging that patient voice. Again, to me, it was such a wake-up call, a personal anecdote, such a wake-up call in that sports medicine surgery, hearing from those young people that they didn't understand the language. And so making sure that you have representatives from your patient population who can speak. Again, no one patient can speak for all patients, but if you get a diverse group of patients, they can help identify some of those barriers that might trip up the people and lead to inaccurate and potentially corrupt data. So having that patient perspective is critical. I would also say just for me, the second takeaway is that attribute grid. I think it was an enormously important piece of work that came out of the TEP. And I know that a lot of effort went into developing that, and just the ability to compare different PROMs side by side and really look at, okay, how do the psychometric properties of each stack up? And then also, how do the translations stack up? How does the cost stack up? How does the scoring stack up? To me, that's really important. And as we move forward into the patient-reported outcome performance measure work, we're revisiting that attribute and looking at how it needs to be modified as we look into the next step as far as performance measures. Teresa, anything you would add?
No, I think you covered it. Thanks, Chuck.
Thank you, Chuck. Teresa, maybe can you talk a little bit about sort of provider perspectives, so kind of key takeaways in terms of maybe the challenges associated with not just selecting, but actually implementing a PROM into their workflow?
Sure. We did hear a lot about perceived burden and implementing those PROMs into the workflow. I think that a lot of people and a lot of clinicians view the PROMs as kind of that sheet of paper that people fill out before they go into their appointment. And so we did try to emphasize trying to garner that technology, to garner that capability, possibly get that information ahead of time via the patient portals, and have that feed into a sort of dashboard that the provider can open up and reference during that clinical visit. I think creating that line of it's a real result, it's a working number versus it's a sheet of paper kind of on a clipboard that goes into a file. I think drawing that differentiation and making that example did help people buy in, understanding that there are a resource that is resource intensive and can take a little bit of time and coordination with IT departments and things like that, but it all does start back with those selection of patient-reported outcomes and what's important to the patient, what's important to the clinician, and then drawing those steps forward. So I'll add or see if Chuck has anything to add there.
No, I think you touched on an important piece there, Teresa. Thanks.
Thank you both. We got a question in the chat. The report does not discuss experience of care measures like the CAP survey. Why did the TEP think that those measures are different from PRO-PMs?
That is a wonderful question, a source of a lot of discussion there. So there were a couple of reasons that ultimately led to the decision to focus on the quality of life and functional status and symptoms. One thing I want to emphasize, though, by no means was there any expression from anyone on the TEP that the experience measures and the health behaviors measures are not important. I just want to clarify that. But there are methodological differences in how the data are collected. CAPs are, I would say, the most widespread use of, or widespread example of patient experience measures. And the methodology of collecting those data is very different than the methodology of collecting, say, giving a patient a PHQ-9. It's a very different process. And similarly, there was a lot of discussion, even in the public comments on the final report, about an emerging trend to really view patient-reported experience measures differently from patient-reported outcome measures. Understanding that the experience measures are typically focused on how well a provider or a practice served the patient, whereas the outcome measures are focused on how well the patient did. So it was refreshing to see that theme emerge in the public comments as well, as far as a desire to really view experience and outcomes measures equally important, but not the same.
Thanks, Chuck. That's a great answer. We have another comment from the chat. Was there any discussion in the TEP of the use of PROs that may be administered by a payer rather than a clinician? So, for example, social determinants of health screenings during new member enrollment?
Teresa, keep me honest here. I don't recall that there was discussion of the payer. Again, since our audience for this report was really focused on those frontline clinicians who are looking to identify the outcomes they want to track and figure out the tools and the workflows to collect those data. We were very focused on the clinical setting, whether it's an FQHC or a private practice or a health system. I do not recall specific discussion around payer use of patient-reported outcomes or PROMs, but certainly an area for future investigation. Teresa, any recollection on your side?
Agree with your recollection. Payers did come up in the incentive conversations that I touched on earlier. how to build in PROMs to incentivize providers to maybe conduct those in the clinics and in the settings, but no, not the distribution or collection of the SDOH, especially from the payers. That was not covered in that test.
Thank you guys both so much. So we're running short on time. So I have 2 more questions teed up. So I think those will be the last ones that we get to. But if we get any additional questions in the meantime, we can always submit those to NQF to respond to via email. Okay, so in terms of future goals and considerations, one of our attendees would love to hear if the TEP identified opportunities for creating and using PROs and PROMs focused on communication skills in the context of experience with care. So this is where person-centered care is relevant and resonant for patients or caregivers to report on their experience of being heard and understood, trusted and respected, and all of which are foundational to health equity. So can you elaborate on any discussions that may have been part of the work that you guys did?
I think the person who posed that question framed that beautifully, and I think that summarizes a lot of the discussion that happened in the TEP. In that, again, those experience measures are so important when we look at communication. We look at not just communication from the provider to the patient, but was the patient heard? Was the patient respected? Particularly when we're dealing with disenfranchised populations, people who have not received optimal healthcare or have been somehow victimized by the healthcare system. Tracking that experience is really important. For the sake of this report, the TEP really wanted to focus on the implementation of those PROMs that are largely in complete control of the health system or the clinic, from data collection to data analysis to using the data in the clinical setting. So again, that's part of the rationale why we focused on that. But again, there was discussion along the lines of what you mentioned, and I think I can speak for the TEP in saying yes, absolutely recognition that that is a critical part of health equity.
Thanks very much, Chuck. All right, now for the last question, this is from Mike Saka. So can you talk a little bit more about the tension or balance of the adoption curve, especially where it's EHR driven? So in other words, how to balance the reality of inherent patient provider implementer burden in the shorter term for the longer term greater good?
I could talk about that for a long time. I will try not to, but I mean, that is such an important area. And it goes into, I mean, we can quickly go into looking at interoperability of how data are collected and stored in EHRs. We can look at just the general level of burden that providers perceive with EHRs in general. The challenges, I think one of the huge opportunities that came out of this TEP is the need to get those scores, those longitudinal data in front of the clinicians in the exam room at the follow-up visit, so they can, respond to that the same way they would look at a blood pressure trend and recognize immediately that a patient's blood pressure has improved. So I think there's a lot of opportunity to figure out new and creative ways to engage with the EHR and reduce that burden. I hope I touched on your question there, Mike, but yeah, that's a big question.
Thank you so much to both Teresa and Chuck. It's a great presentation, and really appreciate all of the participation and engagement from the audience. I just want to make you all aware of a few important events that are coming up before we run out of time today. We do have a couple of pre-rulemaking events. So you can join CMS for the 2021 pre-rulemaking season kickoff webinar next week on March 30th from 1 to 2:30 p.m. Eastern time. You can register via the link there. And then CMS is also offering a CMS Merit Tips and Tricks session. So for those of you who aren't aware, Merit is the system that has replaced JIRA for submitting measures to the MUC list. So if you haven't had an opportunity to learn about that yet, April 8th is your chance to do so. And then if we could just jump to the next slide quickly. Thank you. Next month, we have another info session, and it's going to be an update on the work of qualified clinical data registries, or QCDR. So if you have any interest in registry-based measurement, that is the presentation for you. And then I also just wanted to note that in case you missed it, our February info session, which was on transforming measurement for better care, lessons learned about patient-centered measurement, is now available on YouTube at the link here. So again, thank you all so much for your participation today. Thank you again to our NQF colleagues for their informative presentation and the great work that they continue to do. And we hope you all have a great rest of the week. Thanks, everyone.